Good day, everyone. We'll be starting our event in just about 2 minutes. Good day, everyone. I appreciate you attending today's event. I'm going to introduce you to Joe DeSerio, who will kick off today. Thank you very much.
Good afternoon, everybody. Joe Desiderio from the New York State Chapter HIMSS Programming Committee. I'm just going to go through a little bit of housekeeping, then I'll turn over to Rob Zampolin, our moderator for today. For logistics, live captioning if you need it, the CC button at the bottom in the video controls, please use that. Any questions, pop them into the Q&A. I'll be moderating that as well for anything for the speakers or the moderator if it needs their attention. If you need any technical assistance, try and refresh first if you're in a browser. And we are recording this. It'll be up on the HIMSS chapter YouTube channel and website within the week. Next slide, please. Thank you. And please, if you're not already a member of HIMSS, we've got a bunch of guests today. Consider joining. You can use the marketplace link that's there on the screen or the QR code. Just zap that. And of course, just hit the chapter website and the link on the screen as well. So without further ado, I'm going to turn over to Rob Zampolin from Veritas to take us through today's program.
Thanks, Joe. Really appreciate HIMSS having Veritas as a sponsor. We're longstanding healthcare focus in Veritas, and we really appreciate the partnership with HIMSS. We're really excited to have the panelists we have here today. We have Dr. Noreen Brennan from the Chief Nursing Officer from Hospital for Special, New York City Health and Hospitals. We have Terry Vetter from Northwell Health. We have Dr. Sandeep Poulin, Chief Medical Officer at Blue Stream Health. And we have our Chief Technology Officer, Rick Bryant from Veritas. I think we're gonna have a great, insightful session here. So without further ado, I'm gonna get into it. What I'd like to do first is have the panelists just describe their roles within the organizations, and we'll start with Dr. Brennan.
Hi all, thank you very much. As he has said, my name is Noreen Brennan. I am the Chief Nursing Officer at New York City Metropolitan Hospital, located in the Upper East Side of Manhattan, in a little place called El Barrio. I am part of New York City Health and Hospitals public health system. We comprise of 11 acute care facilities. We provide healthcare to New Yorkers regardless of ability to pay, immigration status, without exception. At Metropolitan, we've been involved in every major effort from providing treatment and care to the sickest patients in the earliest days of the pandemic through testing and most currently vaccination today. We had a very interesting time during COVID, in that, as you might have seen in the papers, New York City hospitals were particularly hit, especially in some of the more densely populated neighborhoods.
Yeah, that's very true. Being in New York, it's been amazing to watch the rise and thankfully subsequent fall of the numbers within the hospital organizations in the pandemic. And so let me turn it over to Terry Vetter from Northwell.
Good afternoon, everyone. My name is Terry Vetter, and I work at Northwell Health as a Director of IT for Emerging Application Solutions. One of my key areas of focus is telehealth, along with patient monitoring and ideation, as well as innovations and ventures. From a telehealth perspective, we've been heavily involved in the in-room and in-hospital solutions, and the pandemic obviously had us rise to the top from a focus of ambulatory and how we provide services to all of our needed patients that are unable to be in a facility, or it's safer for them not to come into a facility. So during the pandemic, we had our share of new ways to do business and how we get there, and what we can do to improve patient and provider experiences. So I'm anxious to talk today.
That's great, Terry. Dr. Poulin?
Thanks, Rob. Appreciate the opportunity to join all of you on the panel today. So I'm Sandeep Poulin. I'm the Chief Medical Officer of Bluestream Health. And if you haven't heard of Bluestream, we're actually a platform as a service. What that means is we provide digital toolkits for health systems, health plans, and clinics to build out and deploy electronic digital front doors and improve the digital experience for patients for accessing care and for those partners to deliver that care seamlessly. So you can actually build and design your own custom telehealth and virtual care experiences using our platform. Look forward to today's discussion.
That's great. And last but not least, my friend Rick Bryant.
Hi, guys. Thank you so much. I always enjoy taking part of the HIMSS organizations, and it's a real pleasure to speak with y'all today. My name is Rick Bryant. I'm the Chief Technical Officer for Veritas. I spent 20 years in the provider space, and now my job is to understand the needs and the changes, the drivers within the industry to make sure that our product set provides solutions for the healthcare industry. And with all the changes with COVID, I'm very excited to talk about telehealth and how healthcare has emerged. So thanks for having us today.
That's great, Rick. Really appreciate it. So I want to jump into some of the questions. And I think the pandemic had such a huge effect on us here across the country, across the world. What I'd like to dive into is at the very early stages of the pandemic. How did you handle it? What were the challenges you first felt within the healthcare organizations, Dr. Brennan?
So it's very interesting. You know, we have been watching what was going on in other parts of the world prior to the pandemic. So we actually started our preparations back in September and October of 2019. And with that, what we ended up being able to do was to really think through what our allocation plans would be, where would we be sourcing supplies from, and truly what would we be anticipating as part of that, that immediate need. And even though we prepared and we really tried our best, you know, sometimes what we fail to recognize is the age of some of the buildings that we're in, some of the competing priorities when it comes to either wireless networks or systems, and sometimes the interoperability that occurs. You know, yes, it can all look very good on a blueprint, but if you have providers and nurses who are not familiar with the logic that goes behind some of those systems, those are all the best laid plans that can come together. What we really did find was that it was an organized chaos, and it truly was organized. You know, I mean, it was a little chaotic, but it was organized. We also experienced an information overload. Everybody wanted to help, but we really didn't know where the best places were to help. What we did eventually come to realize was our new normal is that we had to be very fluid in our changes, very fluid in our adaptations. We had to be very succinct in what really truly did work and what didn't work, because if the providers had any problems with utilizing any of the technology, they just didn't use it, and it just took up room. So those were kind of some of the initial things. And you know, one other big initial thing was that we stopped providing the usual services that we were used to doing. We shut down all our ambulatory care clinics. We shut down all our ORs. We shut down all of our endoscopy suites. So we had people who were set and ready to go for their procedures who all of a sudden now were out there with no connection back to us. And that's really where our IT partners came in and really assisted us with setting up some of the telecommunications to our ambulatory and outpatients, because people still were getting sick. It may not have been COVID, but they still had other ailments. They needed prescriptions renewed. They needed home health care referrals. There was still, life still went on even amidst during the COVID. So that was kind of what we were experiencing. It was almost like an out-of-body experience. There was so much coming in, and you just kind of went, okay, just let's set up for the next thing. So that was one of the major things that I saw.
Yeah, definitely a true definition of a frontline worker, right? It's amazing to hear the stories, and it's just makes, I think, everyone here and everyone listening so much more appreciative of what the work folks in hospitals do. Terry, how about you? Same question. What were the initial thoughts, initial challenges Northwell had when COVID started to bubble?
From an IT perspective, I look at it a little bit differently. And some of the things that we ran into were new. I mean, we always knew we were going to be using telehealth for more of an ambulatory solution, but we had been successfully using it in hospital for a long period of time with dedicated equipment, dedicated training, dedicated support. It was running very smoothly. When COVID hit, not only could we not expand what was working great, right? Because we couldn't get into rooms, nobody wanted to go into those rooms to expand. But then we also had the challenge of how do we reach out to all these people who are remote? And now we're talking about using not our equipment and bring your own device, which is a whole new world, right?
Yes.
And you're talking to people who don't know how to use their device. Like they don't know how to turn their camera on. They don't know how to connect. They don't know how to read their email. So we quickly jumped on a board to integrate with other applications within our solution suite, like the digital patient experience. This is like a normal way for a patient to access their records. So could we build telehealth into that and have them have a more unified way of getting into their sessions, just like they would if they were making an appointment to go to an office? So we had to run into those scenarios. We also had to talk about, how providers were working remote and how they could connect. And, do they have the right equipment? Do they have headsets? Do they have the right environment to have a private conversation with a patient? Do they have enough bandwidth at home to handle the audio visual and all of the connectivities that they were having? In addition to that, we also had the scenario where all of that could work, and then the internet or our provider who was handling our telehealth couldn't handle the sheer amount of calls that was coming in through their scenarios, and they've added additional connectivity for us, but then there were so many jumps that it was taking too long to connect, or there was a number of dropped, or those videos where everything's just kind of digitalized, so like you have all this breakup and these little weird boxes on the screens, which was very disconcerting to people. So it was a change in how we had to think about how we do business and work with our patients, as well as our providers who are remote, because we have 68,000 providers that we're working with that you have to make sure that they have that same capability.
Yeah, I guess similar to Dr. Brennan's kind of organized chaos in a sense, right?
Exactly.
You hit with the new normal, and you just had to grin and bear it and do what you could. Dr. Poole, let me ask, with your organization, with the company, the healthcare organization you've spoken with, what were their feedbacks to you during this time, during the initial stages of COVID?
Yeah, I was just, while everyone was talking, I was just trying to recollect back to March. It just seems like so long ago that we've all been through so much. But yeah, everything that Noreen and Terry kind of reflected, from being on the other side of the fence as part of the team that was trying to support the needs of these healthcare organizations from a technology standpoint. I spent a lot of time making sure that our workflows that we were enabling were correct and that our team was able to meet these requirements. And fortunately, we were able to, so one of our large health system partners, like Terry said, were looking at tools that were already in place to expand, and unfortunately some of them couldn't, right? So when you were doing 7 video visits a day prior to COVID, you could handle those, right? That wasn't at scale. Now imagine doing 5,000 of those when 90% of your visits flip from in-person to virtual, and deliver that in a timely, stable, effective manner while enabling those workflows that your teams are used to. And fortunately, just like Terry said, a lot of these tools that were being used in hospital settings now really didn't translate to the external environment where patients were, where your teams were now located. So that's one of the biggest challenges that we had to overcome, was how do we take, and fortunately, because we're built as a technology platform that was API driven, we were able to quickly adapt. So in 2 weeks, we were able to do a single sign-on process, onboard 15,000 providers, and took them from 7 visits a day to over 5,000 visits a day. That was just one example. But more importantly, we also were able to offer free resources for the smaller clinics and doctors' offices that couldn't keep their doors open, right? Because they had to shut in-office visits. So we built a free resource. We just called it Rapid Response. And being a New York-based company, we were actually recognized by MD Calc as being able to give this resource to New York doctors. And so we had 95,000 providers sign up over the course of a couple months. And it's in the first 3 weeks of COVID, we had over 2,000 independent doctors sign up, and we were delivering over 11,000 minutes of free video sessions because they were trying to use non-HIPAA compliant tools, and we knew that that wasn't sustainable a long time. So yeah, I can tell you more of these stories, but that's what we were seeing behind, the other side of the fence, was like how were your partners that we were supporting, the same challenges to, make sure everything was stable, everything was still HIPAA compliant, all the technology worked, and, support the needs that both the doctors and patients were facing.
Yeah, that's great. Again, same kind of concept, just, changing on the fly, being nimble, being an organization that's being able to react to what your clients need. I think that's incredible. So Rick, similar for Veritas, you talked to our largest healthcare clients across the country. What did you hear from the get-go, and what were our major response?
Well, it's great to hear, because I echo everything that everyone said. We saw initially hospitals were very worried about spinning up surge capacity, right? And traditional procurement cycles were really challenging. And, we try to be a trusted partner. So Noreen, I apologize. I added to that chaos because I reached out to my healthcare providers and said, hey, look, we always want to sell you something, but now you guys are our heroes. How can we help? So initially setting up surge capacity, and then it quickly moved to being able to set up remote workers. And they'd never done that. To echo Terry, they've never worked from home before. How do you have that kind of controls and that good quality medical treatment when everybody's working from home in all kinds of chaos environment, dogs barking, kids screaming, the whole 9 yards? Then it very quickly shifted to enabling telehealth. And I can't stress this enough. There are major hospital systems where initially they might use 4 or 5 different video conferencing platforms. And so the experience is different for all the patients, and the capabilities were different for a lot of the providers. So how do we make that more of a sustainable practice? And then ultimately where we really came down to is how can we help healthcare continue to drive this huge data growth, but lower the cost, because all this shutdown of the discretionary services had huge budgetary shortfalls for major health systems. I talked with one health system, they lost over $1 billion in revenue from those discretionary systems. Think about that, $1 billion. So right now we're working with them to build these more sustainable practices and to help us move forward, because I think that telehealth, now that it's out, as Terry mentioned, we've been trying for 10 years to make this work. I've seen more advancements in the past 10 months than I have in the past 10 years. And it all comes down to both necessity and getting reimbursed for it. So those are what we saw initially. Just the guidance alone, being able to make sure that everybody's the CDC changed their guidance over 27 times. So how does the modern day healthcare professional know what the good and proper medicine is today when it changed yesterday? And that's one of the challenges that we saw as well.
Yeah, it's amazing. It's complex, complex challenge, a complex problem, and I don't think it's by any means finished yet. I think we have to continue to roll with the punches, and I think everyone in the healthcare industry and healthcare field is going to have to continue to be as nimble as they can. So, as the first few 3, 4, 5, 6 months rolled on, what were some of the changes? What was it like, Dr. Brennan? How did things evolve from the initial surge, as Rick mentioned, to now we're into it about 6 months? And when in New York, as we know, we were very high rates, hospitals very filled. How were you handling it then? How were the initial response you guys were going through?
So it was amazing. We kind of went like 57 days straight. So it kind of started around St. Patrick's Day for us and then ended around Memorial Day weekend. And those were two pivotal dates for us because it seemed like, I don't know where the month of April went. So it was crazy. But what had happened was some really great things during that time period. You know, as well as we prepared for everything, one of the things we didn't really have a great kind of knowledge about was how this was going to impact our patients that came into the hospital. I mean, literally at times, and I know this is going to sound awful, people were literally being dropped at the emergency room entrances and then had no communication with their family. You know, people weren't thinking of, all right, I got my phone in my hand, but what do you mean I have to bring my charger now and other things? So something as simplistic as that became a major divide for us because at times when people arrived, we couldn't even figure out how we were going to communicate with their families. So that was one big thing that, you know, thankfully through donations from many of the IT corporations, we established communications with iPads, whether it be through, you know, Google Hangout or Facebook or whatever platform we use, or FaceTime. We learned a lot about that because, you know, in the hospitals, well, we always had signs up as no use of cell phones, no use of this, because we were always afraid we're going to be recorded. And now here I am directing my staff to go around. No, it's okay. Go with the iPad, record, show everybody everything. And, you know, that in and of itself was a huge cultural change. And as Rick had mentioned earlier, yes, we got transported very quickly from what we were used to doing to a whole brand new world without without having to go through some major legal hoops or regulatory requirements. We know we were already looking at those relaxations, whether it be with the executive orders or with the CMS kind of rules. We were embracing it. We began embracing the technology. We recognized, you know, we didn't realize at first when all this started that our own healthcare providers, and rightly so, were fearful. This was a highly contagious disease that we really didn't know. I mean, I still remember my nurses walking in and out of the building with shoe covers on because we thought it was transported through the bottom of people's shoes. You know, that's how enveloped we got with the fear piece. So when you looked at some of the technology solutions, they were great because in one instance, they enabled us to communicate with the patient either through video conferencing, through transportation of vital signs to a main central monitor. But it really, we really began to fall into a groove, especially regarding the new technology. And we got a little crazy. We wanted more. We want more. But, you know, that's just coming, you know, from the provider side. But, you know, any other type of thing that we would have put in would have taken a year. It would have taken 6 months planning. Our team here had things in within 24 to 48 hours. I mean, it was just absolutely fantastic. So that's what we saw as we, you know, as the surge kind of let up a little bit. And when the second surge came around, we were really much better prepared. Much more able to adapt.
Yeah, that's great. That's great to hear. So Terry, same question for you. Again, surge happened, the initial response, and then a few months into it, how did you guys handle things?
So, you know, I would echo exactly what Dr. Brennan said. You know, we're definitely focused. We went from 100 users to 9,000 users for ambulatory telehealth. So, you know, we came up with quick processes, how to get people in, you know, how do we get people in our Active Directory and get them in the right group so they can see the right information and make it seamless to them as quickly as possible. Also purchasing equipment. So making sure people had headsets and cameras and all the things that, you know, we said, you know, there were so many shortages. So we got very creative around that. We actually leveraged, you know, the Amazon, the Echo Shows for nurse stations so they could actually communicate with their patients. We purchased certain kinds of tablets that had not only ways for the patients to communicate with their family, but entertainment for them. Like, what could they do while they're sitting in this room so they're not like just scared out of their wits? They could watch movies, they could email to people, they could text to people, they could, you know, play games, whatever was appropriate for them, without having somebody be in the room with them and all the appropriate equipment associated with those things. And, you know, now we're looking at the room of the future and how do we move forward with that? We became very innovative about, you know, how we could quickly improve the patient experience, the provider experience, and what that means for the future. You know, we have over 19 hospitals. We shifted some hospitals to be non-COVID hospitals, so we could then start providing services where people could come in and not be fearful of COVID. And they became COVID clean hospitals. We worked with New York State and partnered with them. We were providing telehealth services on the ship in the city. So, you know, we donated a number of people and equipment and made sure everything was up and running there, and was able to keep track of all of that data as well as equipment to make sure people could get the services that they need. So there was a number of things that we had to stay focused on from a technology perspective and from a community perspective. So. Yeah,
that's great to see such, you know, large organization as Northwell be able to be nimble and react to the trying times and be able to be as really aggressive or progressive even with the cards that you're being dealt. So Rick, let me ask you from a technology provider perspective, you know, we're seeing telehealth, you know, starting to rise. So what's our focus? What's Veritas's focus on telehealth?
So it's interesting, Rob. Well, I went back to our team and I said, look, hey, this is a new normal, right? Everybody, not just healthcare, is going to start embracing this audiovisual type of technologies. And when I went to talk to my product team, they're like, oh, yeah, well, we already have tools and technologies that we've used to harness and improve compliance and sustainability around email, around social media. So we just added this as a new data type, right? You're leveraging a legacy, a 15-year-old proven technology to be able to harness all these video sessions. And to Noreen's point, this has provided great benefit for continuity of care. Just the improvement in the communication stream is tremendous for a patient. Not even talking about the patient satisfaction. Me as a patient, I'm much happier to not have to go into a hospital where I run a chance of getting an infection. And when you tie that back to the core of the Affordable Care Act, that's exactly our mission, right? Keep healthy people out so that we have room for sick people and to not encourage or increase hospital-borne infections. But that being said, I think a lot of the technologies, to Dr. Pullum's point, is that we put a lot of focus on just getting these technologies out there. Now we have to kind of regroup and figure out how to make them sustainable, how to make them into a learning process to be able to feedback from that. And some of the things that I'm really encouraged around is that by leveraging the telehealth, not only are you able to serve those patients, but you get so much information that you can learn from, right? I can't think of any other technology that has such a comprehensive capture of the entire patient-physician relationship. And when you go back to the core of being able to improve medicine, imagine what we can learn from all those sessions. So that's where we're focusing right now, is being able to take that innovation and put it into sustainable practice, because we believe it's going to go forward.
Yeah, I agree. I think it's definitely, we're scratching the surface here from a technology perspective, and you have to move forward and evolve. So Dr. Pullum, same question. So how's your organization viewing, you know, the rise of telehealth, and what are you doing, you know, to work within its, you know, within its barriers?
Yeah, no, you know, one of the learnings from COVID, it actually taught doctors, nurses, care teams how to use virtual care methodologies to deliver care, and for patients to trust and actually be able to receive care without having to be face-to-face. So that was one big learning. The other thing it showed us was that it actually expanded the digital divide, the inequities in health, where people didn't have access to the tools and technologies, especially for patients that couldn't communicate if English wasn't their natural language, or deaf patients who now needed connections in the video call. So fortunately, because of the way our tech stack worked, and this is a great example with New York City Health and Hospitals, for patients that couldn't come in due to COVID fears, how could they get access to care when they didn't have access to those face-to-face encounters? So New York City Health and Hospitals launched a great service called expresscare.nyc, which allowed any New York State, any citizen in, any person that's in that New York area, 20 million plus people, with single-click access to go to this web portal and be able to know that you can now have language support in 200 languages in the video session on demand, which has never been done before. So, I encourage you guys to go check it out. They did an amazing job, the team there, to make sure that everybody was included in access to care. So that was a great project that we were able to help with.
Yeah, that's fantastic. I think it's so eye-opening to see the organizations develop solutions for this challenge, and it's going to be really interesting and very cool to see where it goes and how it develops. And on that kind of train of thought, Dr. Brennan, how are you guys thinking about evolving from where you are today? So where's your telehealth solution going to go in the immediate and then the not so immediate future?
So great question. Let's take the easy part first. For those that have that access and have the ability to internet and to devices, it's an easy win-win, right? We've seen a huge increase in the activation of MyChart, which is our Epic solution for the electronic medical record, where, at one point in time, we would have people coming in just to refill a prescription. Now they can do all that online. That's just a very simplistic idea of what they have. Many times, for those of us that have 1, 2, or in my case, 4 kids, you're always looking for the annual health assessment for some sports activity or something. Our system gives you the ability to print it out. Even as a nurse, yes, I do know the immunization schedule, but Jesus, I can't remember when I had all these kids have all these immunizations. So simplistic things like that for people who have the access and the internet is great. And that is really, truly the place we want to get to in healthcare, so that people are driving their own well-being in partnership and in collaboration with the nurses and physicians who are doing their care. However, we can't ignore or address or fail to address those that still don't have that type of access. I think one thing that I've learned external to the hospital environment is that not everybody has access to internet. Not everybody, not all of my patients have nice fancy iPhones and Samsungs and Galaxies. I have a group of people that still have flip phones. What do I do for them? When you look at people who may or may not have a computer in their house, when the libraries closed, that cut off a whole internet world for these patients. So for me going forward in the future, does that say to me now, you know what, Noreen, why don't we start replacing our waiting areas with an area where patients can connect using our computers, our internets? How are we going to change what we've always typically done? We used to have the phone call to the doctor to set the appointment, and that was how we did it. Well, we don't necessarily need to do that anymore. We don't necessarily need to be bound by typical work hours. We have a lot of different opportunities here to increase our access and the availability of how we care for people in their homes. We can put a patient in their home with a blood pressure monitor and a pulse oximeter and a temperature monitor, and we can have that information sent into nurses who can look for the trends to see, hey, you know what? Yeah, it's time for you to come in. So I think we need to start leveraging that, but we have to be cognizant of, like Dr. Pullum suggested earlier, language is a huge thing for us. Which we were so glad to have that partnership, because a lot of our clients, English is not their primary language, and they do need to get healthcare in the language that they're most comfortable with. There are the just general issues of devices. One of the issues that we ran into is that while we had high fancy gadgets on one side, the receiving end couldn't receive it, because they did not have, like Terry and Rick have talked about, they just didn't have what they needed. I don't know the technical term. I'll leave that to you guys. But they really just, they just really didn't have it. And, had we not had COVID, although COVID was not fun, I don't know that we would be as well versed today. I think it would have taken us a good 10 or 15 years to really actually be able to quantify this. The amount of research that's come out with telemedicine, the big, large data sets now that we have, the AI for the clinical decision support, all of that was fast forwarded for us. And I just want to say thank you to our IT colleagues and our medical partners, because that was truly a great bit of work.
Yeah, it's clearly amazing to see how this has affected data growth within organizations, something that Veritas handles, very well. And it's amazing just to see it on a scale that I don't think the industry thought it would ever get to. Dr. Pullum, your thoughts on this evolution of the program? Where are you going next? What's your forward thinking?
Yeah, no, that's a great question. So, as one of the things that COVID is driving forward is the policy catching up with, the regulatory framework for reimbursement and care delivery outside the typical, for example, that there's now the ability to have the patient receive care in the home, right? The idea of site origination is going out the door, and the ability now to have hospital at home services that Noreen indicated that are now reimbursable. So I think that that's going to continue. So those waivers that kind of went into effect are hoping that a lot of those are going to stay permanent, so that this now becomes a normal way that care is delivered. It's no longer going to be called telehealth. It's just going to be part of healthcare. And the second notion of that is the other thing that a lot of folks have learned is it's not just about that one video visit that you have with your care team member, but now how could you actually build a whole virtual care delivery paradigm where you can, seamlessly take that patient and build that patient-centric model where you have seamless handoff and transitions between the care team all in that encounter. So you can, it's the distance isn't a barrier anymore. You can now have a home health nurse that's taking care of a CHF patient or a diabetic patient with a foot ulcer, literally have access to the wound expert or the cardiac expert who can then have the resources for having supervised expertise care without them physically there, right? So that the ability now to have that access to those same type of experts where there's a lack of, there's a shortage of all of these resources. So I think where we're moving is the ability to deliver the best care possible wherever it's needed using these new care delivery methodologies.
Yeah, one of the things that excites me most about the healthcare industry is how collaborative it has been and how it's going to be even in the future. And that's to your point, Dr. Pullum, that it's all about collaboration and how do we get the best result for the patient. And it's a really interesting, cool concept, something I've always thought was really neat. So Rick, talk to me about the evolution at Veritas. How are we looking at the healthcare industry and where do we think we're going to fit in the future?
Yeah, so this is a really good point, and I think it's worth echoing in that Health and Human Service, or CMS, has agreed that they will fund telehealth services through the end of 2021. However, them saying that they have no methodology to be able to do that legally outside of the national pandemic. So when the national pandemic is declared complete, then CMS will have a hard time reimbursing for that. So it's important for all of us in this industry to work with groups like HIMSS and CHIME and your legislators to support what it's Bill S4375. It's called the Telehealth Modernization Act of 2020. And that's going to enable us to continue to develop on that. Beyond that, so that's my public service announcement to try to help us in the industry keep moving forward. There's some things that are coming out of this that are adverse effects. So one of the things that we just started focusing on is physician and clinician burnout. Our frontline heroes have been put through so much fear and stress, like Noreen mentioned, and we've worked them for 10, 12 hours for over a year now, to where unfortunately suicide and burnout is at an all-time high. So what we're doing is we started incorporating in our tool set to be able to determine sentiment analysis. So to be able to passively identify if there's a burnout in someone's voice from their voice stress analysis. It's the same technologies that we use to determine if someone's shopping for pharmaceuticals or maybe not being truthful about their medication compliance, or no, I absolutely don't eat McDonald's every day, that type of thing. But we're applying it to be able to help our physician community, and they really need our help. Also, there's a lot of deep learning and clinical applications that can come out of this, right? To be able to improve this workflow for continuity of care, moving from outpatient to inpatient to post-acute care, being able to leverage those artifacts and transfer that knowledge to improve on the outcomes. So that's where we see it going, and that's where we're trying to prepare to suit those tools moving forward.
Well, it's a very interesting concept about the clinician burnout. I don't think any of us would have ever dreamed about something like that. I mean, I think everyone gets in their profession, especially doctors and nurses, because they love what they do. But this is really, this pandemic has push that to the limit, I'd imagine. I mean, I'm sure those folks love what they do, but that's an interesting perspective, and it's a very tough challenge I think we're all going to have to face going forward. So Terry, for you guys at Northwell, so you were a little bit ahead of the game. We talked about you were evolving, but now where do you think you're going to get to? Where you're going next?
So we're going in a couple of different directions, where we're working with some of the facilities who are identifying scenarios where they don't have, where they have a high population of community where they don't have capability. So we're setting up kiosks, we're setting up special offices with divided iPads where people can come in and actually not only get their information, but actually have a telehealth session if the doctor is not there. So the doctor can be anywhere, provide them a telehealth session, even though they're coming in, as opposed to the doctor and them both coming in. So I think that that's very helpful. We're setting up the ability to how we streamline what's available in the patient's room even. So now we have an iPad for the patient. We have, an Amazon show for the patient. We have a TV for the patient. We have telehealth monitors for the patient. We have patient monitoring for the patient. There's all these cables, all these equipment in the room. And it's a fear factor for patients. They go into a room with all that equipment in it, and it's a very overwhelming for the patient, for the provider. So how do we streamline that and look at the room of the future? And a key component is going to be interoperability. So how do we have all these different applications that can communicate to each other, provide the right function, shift on and off when needed, and show priority, right? So now we're going to have alarm and alerts for everything that's going to be mobile, because we want everything mobile, and we want the world. We want everything to tell us everything. But that becomes another type of fatigue, right? Alarm and alert fatigue. So if you have 10 applications on your phone and all of them are beeping at you, what's the next step?
Scatterbrain, right?
Yeah, Terry made me think of something else, and that's another innovation in that, with computer physician order entry, we have made our clinicians spend literally half of their time documenting the record and only half of their time seeing the patient. And Terry, you made me think about this because I've been thinking about remote care. We haven't talked much about in-room care. But with leveraging the technologies we have today, we absolutely have the capability to be able to harness that conversation and create that documentation on the behalf of the physician. And what that does is that makes their lives better. They want to treat patients. They don't necessarily want to do documentation. And for the hospital system, it literally doubles their throughput. By creating that record on behalf, by harnessing that transcript or harnessing that conversation, they can see twice as many patients in the same amount of time, or conversely, have twice as many resources treat the same number of patients. So I think that's going to be a big advancement moving forward. And I apologize for circling back, but Terry, you made me think of something really important.
No, it's definitely very important. We're thinking about how to harness things like RTLS. We track all of our equipment. Maybe we need to identify who's walking into the room so you don't have to announce yourself. It announces it on the television. Like, there's a number of futuristic ways that we can look at things and be innovative to provide better service to our patients as well as our providers. We can't lose the provider in that whole image of improvements.
Right. Yeah, I think that's the big focus, right? We're all in the business to provide for the patient themselves, and how do you do that the most efficient and effective way, and it's a very important concept. So let's take a twist here on telehealth programs, and let's talk about looking at it from how do we use this as an advantage for us as an organization. Dr. Poulin, how do you think telehealth can be a competitive advantage for organizations?
Yeah, it's a great question. And people, like I was kind of alluding to this before, everyone kind of thought of telehealth as just for that at the time of the appointment or that acute event. But as more organizations are shifting towards value-based payment models and for care delivery wherever the patients are, wherever the resources are, having access to, you really should be starting to think along the lines of how do we virtualize care? How do we digitize the care delivery paradigm itself? And so once you start thinking along those lines, the ability to have these workflows, so depending on if you're in the EMR or if a patient is coming to you from the patient portal, or in the New York City Health and Hospital example, it's an on-demand scenario, right? So whatever that touch point is with the patients, your system needs to be able to seamlessly understand where the care request is coming from and how do we provision against that requirement. So you can kind of create these digital front doors, if you will, for that access and have the resources allocate. So I didn't talk about this. So one of the key patents that we have on our technology is this provisioning engine, right? This ability to look at those requests for care, and then how to use those existing resources within your organization. If it's a nurse or a diabetic, nutritionist, or if it's a physician, you should be able to understand what the needs are and use your existing resources efficiently to deliver that care. So don't think of virtual care as just that encounter with the patient, but that experience on that pre-encounter and post-encounter and how you create that service around that need.
Yeah, very, very interesting evolution of, we're today and we're going to go tomorrow, and the notion, I think, of following the patient or following folks, again, back to that collaboration. So Rick, same kind of concept. Where are we sitting from a competitive advantage standpoint with the evolution of our telehealth program at Veritas?
Well, I think this is another really critical point for our hospital organizations, because we've enabled telehealth, that has allowed a lot of competitors. Just in the New York City metro area, there's 37 new telehealth only services. And what that's doing is that's literally cannibalizing patients from our brick and mortar hospitals. There's always going to be some need for inpatient services, blood draw, medication, injection, that type of stuff. But if we have these other competitors pulling away, what we're looking at, probably 50 to 65% of our visits could be maintained in telehealth. That's a big problem, because we have to support those telehealth, those brick and mortar institutions, right? So it's not just a competitive advantage, it's a necessity, right? You have to have a good patient experience. You have to get them to bring in. It's a benefit to the patients because it provides a continuity of care, right? If you can do most of your stuff telehealth, but then when I do need to go into a doctor, they have my history. That's a real benefit for that continuity of care. So making sure that we approve and keep this moving forward with a high level of patient satisfaction is going to help our HCAP scores and improvements. We've put in our technologies the ability to be able to supervise and provide compliance and demonstrate compliance around that. So I like to think of it as like, the early days of the call center, right? They quickly learned that if they do not measure quality, then quality is not going to be paid attention to, right? Same thing is going to apply in the healthcare arena. If you're not measuring patient satisfaction, you're not going to have a focus on it. Similarly, when we get out of the pandemic, there's still a focus on being able to achieve our quality and controls, right? To make sure that everybody is practicing the same good medicine so that we can drive those metrics up and improve the quality of care. So those are the areas where I think telehealth is going to become a necessity for go forward hospital systems.
Yeah, interesting thought, Rick, about a huge portion of what we do could shift to telehealth. And if people aren't comfortable going back into buildings, into hospitals, the rise will, I'm assuming, is could continue. But it's an interesting way to think about it. So Terry, from Northwell's perspective, how do you? I guess the question would be, you're ready to handle more from a telehealth perspective, but is that what you want? Is that what you want to have happen, or we're trying to get back to the more day-to-day workflow where people are coming into the hospital?
Well, I think we have a very variant patient base, so I think that even though we will move forward with telehealth, I think it's going to be some time before it's fully accepted, and I think that there's going to be functionality where certain scenarios just aren't going to be evident for telehealth. Definitely in-house, definitely expanding, definitely from an ambulatory perspective. I think for quick, unsignificant or follow-up type sessions where we're not talking about somebody who is in a serious situation, we'll definitely move forward with those scenarios. So I think that it's going to easily be promoted as telehealth, and I think we want to promote telehealth, but I think that we're also going to be forced to consider how we support all those other different scenarios. So from an IT perspective, our biggest concern at the moment is security. How are we focusing on the security of all these people's data? How are we allowing people to come into our system? How are they receiving the emails that are being bumped by their carriers because of potential malware and things like that? So there are definitely things that we have to come up with and try to solution for as we're going down the road.
That's a great pinpoint for us right here, Terry. I have a question in the chat I want to get to real quick. So what measures are being taken to protect data from remote monitoring within telehealth? So Terry, I'll let you answer first. So in your telehealth program, what are you doing to protect that data?
Sure. So we actually have all of our data coming through specific, very secure methodologies. We use CrowdStrike to monitor all of our ins and outs of data. But we're very, very cautious about that, and we focus on it, and that's why we developed our patient digital front door. We want to make sure that people are logging in with secure information, getting secure information, that it's just not randomly being sent to the wrong person. I mean, people change email addresses, phone numbers all the time. How many times do you get a phone call to your house? I'm calling about your prescription, and it's not you. So how do you keep that up to date? And that's part of our telehealth program as well. Every time an appointment is scheduled through telehealth, we're monitoring, is this your correct email address? Is this your correct phone number? Making sure that we have all the right data on file for those patients. It's not just waiting for them to come to the office to give us that. So it's a random requirement, even when they're logging in. Please confirm this, because we want to make sure that we're capturing all of that right information once they've logged in a secure environment, not pre that. And I think that's a big key factor, especially during COVID. There was a lot of security breaches, right? I mean, unemployment, there were a number of different areas that people just took clean advantage that there weren't people around to be able to validate.
Yeah, that's great. Rick, you had a question or a comment?
Yeah, I'm very passionate about this. I've been a security officer in healthcare. I've been tracking. It's kind of funny. I've been warning the healthcare industry about ransomware for better part of 10 years now, because I saw a correlation between the high value of data and a low expense or budget around security. So flash forward to today, we're in the middle of a pandemic. Hospital providers are specifically being targeted by at least 4 nation state actors that I'm tracking. Absolutely. I just had another CISA alert yesterday. You guys heard about the Pulse Secure alert? You got to pay attention to that. So we've got these nation state actors that are taking advantage of this situation. We have all these new remote workers that haven't really been trained on spear phishing, right? So you have to take a multifaceted approach. You have to protect those endpoints because you're creating thousands of new entry points into your environment. You have to make sure, and I think this is really a challenge. I don't think that a lot of the methodologies that are being used for telehealth today are HIPAA compliant. I think some of them will never be HIPAA compliant, which is it's going to be a struggle for us guys, right? Because some of them we're using because that's the only thing that patient can access. I try to tell my mom how to use video conferencing and then just forget about it. I might as well drive over there and set it up for her, right? So how are we going to be able to do that? At Veritas, we're allowing the flexibility to use the platform of your choice, but to instill those classifications and those policies, whether it's in the cloud, and to be able to bring them back in and harness it. So there are tools out there, but it's a very complex problem that goes everywhere from being able to train our users on the threats, being able to protect our perimeter, making sure that PHI is protected at all times, even in the cloud when we were kind of forced to go there, because that was the only methodology that we had to scale to be able to provide access. So it's something that we're working very closely with our healthcare providers on.
Yeah, great stuff there, Rick. So Dr. Brennan at New York City Health and Hospital, patient data, security around patient data, what's your focus?
So, our focus is actually getting that education out to the providers and to the patients. We all know how easy it is to run a scam or do a scam, to steal an icon that may or may not resemble what something are, but we are very protective of email addresses of our patients. We do have securities in place regarding our registration data, because that's really where it ties into everything. But every day is a new struggle. There's a new virus. There's a new phishing scheme. I don't even know if I'm using the right terms, but you can see I'm learning. But it's almost as if now our healthcare providers, as we do fast forward, or we do take a moment to stop and say, okay, now looking back, what do we need to do? You know what? We do need education regarding some of that stuff. One of the things that we've done most recently is, we've stopped our email exchanges from different outside email addresses just to maintain the security. And that in and of itself was a huge, a huge blow to some of our colleagues, because a lot of us hold faculty positions at other places. So, so there's a lot of heightened awareness around it. I think we may need to do a little bit more heightened awareness, because, it's a hard thing and it's constantly changing. So I would think that would be one of the things we need to do.
Terry?
That also brings up, we have phishing events where we work. So, we physically push things out for people to identify as phishing. And then we actually, there's like awards at the end of the month, how many people found all the phishing events, because we want people to be aware of it and pay attention to it. So it's a way to engage folks. And, I also run the innovations challenge groups. So we actually take insight from our providers and our other staff members, like what keeps you up at night and how can we help you? And we actually put those questions out there and elicit responses and solutions. And those solutions actually get promoted up within the organization as ideations. And sometimes there's dollars associated with them to develop those ideas. So it really engages the people who work within the organization to stay competitive and innovative, as opposed to I'm not doing that. We really want to engage the folks to improve what's around them and understand what their pain points are, because what's a pain point to an IT person and a clinical person is obviously very different.
Yeah, no, I totally agree with you. I just love this notion of collaboration within your organization. Again, I'm back to that, but I've seen it time and time again in the different healthcare providers that I talk to on a day-to-day basis, and ones across the country. It's such a collaborative industry, and it's great to see that you guys are doing it internally and spawning ideas from your own folks and bubbling that up to hopefully productive outcomes for the whole system. So, Dr. Poulin, again, back to data security. With your platform, which you guys focus on, what's your focus when it comes to data security?
Yeah, no, absolutely. Following all the industry standards, we try to take as little of the PHI information as possible. We integrate directly into a lot of the workflow, so we don't touch a lot of the high value kind of PHI information. So a lot of our clients and partners use single sign-on processes, so they're logging in through their systems, and because of the lightweight, we just do the communication layer. Everything is still kind of warehoused in their EMR. So we take a light approach, and the call itself is all end-to-end encrypted, so fully end-to-end encrypted for each participant in the video sessions.
That's great. So I'm going to ask a broad question here. This is maybe a little pie in the sky, but I think I'm trying to open it up for you guys to think about down the road. So, Dr. Brennan, 5 years from now, what's telehealth going to look like in your mind?
So for me, it really is going to be the way in which we do health promotion and preventative care for our patients. I see it as a fantastic adjunct to what we're currently doing, but there is honestly still an art and a science to physical assessment that I don't think can be minimized to a certain point. So I do see there being a big advantage to that. I do see it also being used much more for patients who want to stay at home, for people who may have a chronic condition that can be monitored more accurately at home. And for that group of people, I really think about our patients with COPD, our patients with congestive heart failure, our patients that may be debilitated due to dementia. In all honesty, they may be safer in their homes than they are in a hospital environment to certain aspects. I do see telehealth having a great role in encouraging people to do those health maintenance things that we sometimes don't have the time to check in to do. I don't know, I'm going to age myself here, but I graduated from nursing school 30 years ago. I think there was only 4 adult vaccines at that point in time. I think now we're upwards of 10. So when you just see that in and of itself, that's a lot to continue to go on with. And I do see telehealth having a really great impact in our psychiatric and behavioral health populations. I do think that the idea of having the video conversation, the idea if they are in a place where they don't want to leave their home, we now have a bridge into that home that has now been fast forward acceptable. So I do see a lot of great innovations for it. I mean, we've already seen how great of a help and assistance tele-ICUs have been. We don't really use them a whole lot in New York, but you can see how great they are, even just to give the clinician at the bedside a little bit of input in terms of what they're seeing. It's a great kind of collaboration between the providers. So I continue to see it grow and advance, and you know what, it's okay. The brick and mortars don't always have to be full, but we want to be full with the right thing. I just, again, my biggest thing would be access, the patient's access, and then also working with the providers and making sure that, you know, we've recognized that technology can make things move faster, but what I've learned over the years in healthcare is you don't always want to move faster. You sometimes want to make sure that you have the right safety nets built in so that people are able to recognize problems and issues at an earlier point in time.
Yeah, that's great. Terry, you had a comment?
Yeah, I actually have two around the behavioral health segment. That's a really good point. During COVID, we actually established after hours for student age, students, so they could actually talk to somebody about the frustration or fears that they were having around COVID, and they're changing their life. You know, they're used to going to school, interacting with a lot of people, and now being forced to be in a home environment. It's a very big change for especially junior high school students. So that was something that we worked on. And then along the second part of that, you know, we were talking about, you know, EICU. We have a very strong EICU program here that we're actually thinking about expanding because of COVID into more of a patient monitoring. So we can actually expand that and start watching patients from a more central location, so you don't have to have all these central stations. So you can minimize or consolidate and get more real estate within the hospitals for care. So there's a number of things coming.
Yeah, that's great. I'm looking at it from this evolution of healthcare and how we evolved to meet, you know, not only today's challenges, but in the future. I think it's pretty cool. Dr. Pullum, how about you? Same thought process. 5 years down the road, your organization, telehealth. Where do you see it?
Yeah, no, we're already starting to see some of the acceleration around, having multi-party calls, right? So not having just a doctor and patient, but how do I bring in a family member? How do we add those interpreting services? How do we bring other resources in my clinic or my health system into that? But more importantly, I think they're also learning what is the right modality, right? When can we start texting asynchronously with our patients? How do we then determine which level of service do we need? To Noreen's point, at what point do they come in? What point do we hand them off to a virtual encounter? When can we have that asynchronous piece? So as more systems get comfortable with this type of stratification, ultimately it's going to be more connected, right? It doesn't matter what type of care you need, you're going to be able to match that level with the right type of service line. How much of it is going to be virtual, how much of it is going to be in person. I think that's what's going to be figured out over the next 5 years. You're going to have a connected ecosystem of devices and services that are able to deliver care wherever it's needed at the appropriate level.
Yeah, very, very, again, interesting evolution of where we're going. Rick, so from Veritas perspective, 5 years down the road, what's your thoughts? Where are we going to be? Where do you think the industry is going to be?
Well, it's very interesting. You can get in trouble trying to determine where healthcare is going to go in 5 years, because a lot of it's tied to, they move based on necessity, and I get it. I was there. The patient safety has to come first. And to Noreen's point, sometimes it's better to slow down, and taking a deliberate approach is going to get you further than trying to race to the end and realize you forgot your wallet by the time you get there, right? So take what I'm saying with a grain of salt. But I think in the near term, what you're going to see is probably 40 to 50% of the inpatient visits are going to be telehealth based. that it's going to start, we're going to start harvesting that data, and to Dr. Pullum's point, be able to encourage early engagement, right? One of the things of this pandemic is people with congestive heart failure wouldn't go into the hospital because they were afraid to get COVID. And meanwhile, they're causing more damage. So we need to make it to where it's more accessible. And also to his point, where we have all the communication devices, being able to have email, text, in-person services is going to have continuity around it, which is going to provide great continuity of care. That we'll be able to harvest a doctor session, right, and be able to send that transcript with the instructions to the patient after the visit, to where if they're giving complex instructions, they get a step-by-step, this is what the doctor told me to do. In the long term, I think you're going to see more innovation around it. We're going to be able to learn from these sessions and be able to do automatic prescription refills based on our thresholds and our policies and our guidelines. That some of the more trivial stuff can be automated using machine learning. But also, I think that we're going to start pulling in, just like how we're starting to use sentiment and to automatically identify voice stress to have early indicators of either burnout or maybe dissatisfaction as a patient. They're going to start incorporating things like body gesture. Because they say 85% of communication is nonverbal. That's obviously not the case with me. I talk like crazy all the time, but you can tell whether or not someone's upset, by looking at their structure. So I think we're on the verge of a great evolution, and the big determinants of that is going to be, is the legislation going to keep up with the innovation in healthcare, and how far does healthcare want to take it? And we'll see how far we can get in the next 5 years.
Yeah, real interesting, and actually brings me up to another question I was thinking about when you're talking. So, with all this data now being generated through the telehealth visits, are you folks trying to apply analytics to these programs, and what are you looking to accomplish? So, Terry, let me ask you. So, what type of analytics are you applying with your telehealth program, and then where you're going with it?
So right now we're using a lot of analytics to identify more of adoption and functionality outcomes, right? So, we have surveys for the patient, we have surveys for the provider, we have training for both. And then we also have, metrics on how long the sessions are lasting, how many people are joining the sessions. So we're looking at things like that to identify, what our next growth spurt is, and like what we need to be prepared for as we're rolling this out even further. I think that's one of our biggest concerns, is to make sure that we have all the interpreters appropriately. We have family members to be able to be invited, and absolutely, as everyone's mentioned on this call, having coordination with other providers. Like, can we just call in a specialist when we need one and have them join that telehealth session to encourage the patient to move forward? So I think that those are all really important things that we have to focus on. We haven't gotten to a point where we're looking at the analytics for some of the things we want to go in the future, and we want to be able to have very strong analytics about what types of services we're offering and how we're getting there. We're starting to do that, but we haven't made great traction in that as of yet. So there's a lot to come.
Yeah, interesting. So, Dr. Brennan, same question. So, analytics for you folks, how are you using them?
Oh my goodness, we're using it definitely in the way Terry is saying. We are using it to connect what our patients' needs are geographically with what we're providing, trying to tie back to see, do we have the right services in the right areas that are needed for our patients. Additionally, most of our data analytics, believe it or not, grew out of COVID. And there was a lot of dashboards that were developed, because what we did recognize when we were inundated with the first surge is could we have done a better job with level loading depending on what was going on at each different facility? Because remember, I'm part of an 11 acute care facility. And in all honesty, at the time when everything was going on, people like myself and in roles similar to mine didn't have time to stop and pick up a phone and say, hey, you know what, I got 4 beds, what do you got for me? Instead, we put that into a program which they've done centrally through IT and through the medical teams in central office, and they actually developed a rubric not only with what places were at what percentages in terms of what they could accept, but we also looked at what was the level of stress from an employee perspective that each facility was running on based on average daily census, and current staffing plans. So those analytics in and of themselves were fantastic. Now we're using the analytics to really drive and compare and benchmark what some best practices are regarding surgery, on-time starts, trying to get the businesses back up and going again, because we too, like everybody else in New York, were suspended from doing any type of surgeries until we got to a certain benchmark. So the addition of that analytics helped us to get to a point of being at the 30% mark a lot quicker, because we were able to systematically do it so that everybody was on the same page, so we could move patients around to make sure that no one facility ever got inundated again.
Yeah, that's really interesting take on the use of analytics and trying to balance workloads, balance the environment out properly. So we have a question from the chat I want to get to. So Dr. Poole, let me ask you first. So the question is, what would be your recommendation to create a hybrid model of care for in-person and virtual with against your traditional brick and mortar? Where do you think that's going?
Yeah, I think, it's a great segue from the analytics question, right? Because you now have a better understanding of what type of services are best suited for kind of like that virtual setting or asynchronous model. And you have now the ability to actually increase capacity for patients that actually need to be seen face-to-face, right? That was not there before. So if you look at your data, you'd be able to see, are these kind of like, well visits? Are they follow-up visits? Are like post-surgical, can we do that, checkup virtually, free up that time in the office for somebody that actually needs that face time, right? So I think that's where you start. You look at the type of visits, the coding that you're doing, and then do an analysis around, is this feasible? What are the inclusion criteria that I need to look at for patients that can handle this, right? When I schedule that visit up front, what data points do I need to collect? Can this, how do you qualify a patient for doing a virtual visit? If you have those pieces in place, then you can start segmenting which of these patient populations, which of these visits could be done in a non-brick and mortar setting, and then allocate that slots that you then open up for those patients that do need to come in.
Yeah, really interesting take on, again, back to this not collaboration, but evolution of telehealth as a program. So, Dr. Brennan, let me ask you another question popped in. Is with a lot of healthcare organizations being teaching hospitals, is the pandemic and really the telehealth program initiatives, is it teachable moments for new residents, new doctors coming in? How's that going to change for you? How's that going to evolve?
Yeah, well, I think for all healthcare providers, whether it be physicians, nurses, physical therapy, occupational therapy, respiratory, social work students, initially when the pandemic began, we put all the students out of the buildings. And we put them out for a variety of reasons. The first being that we wanted to ensure that those that could really tend to the patients had the correct supplies, whether it be an N95 or the appropriate PPE. The second thing that we did was that we couldn't control where the students were going, and the majority of the students were living in residence halls. So our fear was that if they didn't take the right precaution, we'd have another issue on the school end, and vice versa, them bringing it in. So very early on, we kind of backed off from having students. Was that the right decision, the wrong decision? I really don't know, because I do feel in my heart of hearts that we do need to have the students exposed to this, because if they're going to have to deal with globalization and emerging diseases going forward, they do need to know about it. This was a little bit different than other things we had gone through, because we really didn't understand the full concept of the disease back in March. What we did do, at least from our perspective, is we reassigned many of the students, particularly the medical students, the social work students, and the nursing students. And what they ended up doing is they actually did telehealth or phone calls to our patients to, one, get an idea if they were safe. We had 1,000 visits scheduled the day we closed everything down. People just don't schedule visits because they want to come visit us. So the first body of work was to really ensure that all of those appointments that we were canceling, that everybody was safe. And our students were phenomenal with that. And we didn't have a perfect system at the get-go, but we did learn. Dr. Pullum and his team brought in a great solution for us at New York City Health and Hospitals, so that as time went on, patients could do it themselves rather than us reaching out to them. So that was a great use of technology in that point. And as time has fast forwarded, what we do recognize is that there is a component that we may have to go back and have conversations with our colleagues in academia and say, hey, listen, we've taught this way for so long. Now, what are the subtleties that we learned that need to be addressed as we continue to teach our upcoming healthcare providers as they go forward? Simple things, just as you can't use an exam room like you use a booth for telehealth. Very simplistic. We were using patient rooms. Everybody could hear the conversation. We had people that were working remotely, and you're right, to your point with the dogs and the kids and everything else, we had to kind of start to set some guidelines. No, it's not okay to go and have your telehealth visit in your pajamas, okay? You want to make sure your backgrounds. What kind of backgrounds were you showing? It's not appropriate to have your picture of yourself with a pool and a floaty while you're doing a telehealth visit. So there were just some subtleties that nobody was intentionally doing wrong, but we hadn't had it to that level of experience. So, I also do think that there is, we always talk about the art of conversation in nursing and in medicine. There is a different art to communication when you're staring at yourself at a screen. I don't know how many times I've fixed my hair today, because I'm not constantly used to seeing that reflection back and forth. So I try to use humor to diffuse some of it, but there is a huge learning curve that we still have to do, and we do need to bring that into our schools and our programs. Fortunately, many of the schools and programs had already started participating in simulation labs, so I think they've already started it. It's just now we need to continue.
Yeah, that's a great comment. It's funny. It reminds me of when I was an undergrad, I took a public speaking course, and it was a terrifying type of course to take, especially as a college student. And now we're, in essence, it's all about public speaking with the Zoom meetings, things like that. People aren't used to that. Like you said, you're looking at yourself saying, "Do I actually look like that?" So yeah, it's amazing. But a great comment. So we're about 15 minutes out. I have a question for everybody. And just based on your expertise, based on what you've done, so I'll start with Terry. So, what best practices have you learned over the past year and a half, and you can impart on the audience?
I think there's a couple. Test. Make sure that everything's working the way you expect, and document. So not only do you need to document, the procedures or the workflows of what to do, but just as Noreen was saying, you have to document what your base criteria is. Make sure you're wearing your credentials when you're providing a telehealth session so they know they're speaking to a doctor. What's your environment around you? Don't go to a Starbucks, don't go out on a golf course. And, we actually for the longest time pushed back on providers using mobility for telehealth. We didn't want them to use cell phones because we didn't know if they would take that into account when they were, I'm driving home, I'll take a telehealth call. You don't want those scenarios where you're putting people at ease, but also in a situation where others could hear their story. So it's very, very cautious. We actually have a bulleted list that was distributed. What kind of equipment do you need? What do you need to be connected to? All the things. Make sure you have 2 screens so you can document on one screen and look at the patient while you're talking, as opposed to trying to type and talk to them at the same time. We came up with a number of things like that. Other things, lessons learned were training. We used to do a train the trainer model, and now we're looking at online training, CLI trainings, as well as train the trainer models. And then really understanding the workflow, things that we didn't take into account for telehealth. When we're scheduling telehealth visits, in the past, telehealth was more like on the fly. But now we're doing a lot of scheduled visits, and we need to account for, the office manager might need to speak to the patient before they see the doctor, and we didn't take that into account with the workflow. The workflow is that the provider received the notification to go to the session, maybe not the person in the office. So we had to, rethink about some of what of our clinical workflows would be to make it more successful for the patient and the provider. So those are the things that, we took into account right off the bat. There are a number of other ones that, I would share with anybody who wants to talk about. I want to give everybody a chance to talk.
No, that's great. So, Dr. Pullum, your thoughts, best practices, what you've learned over the last couple of years.
Yeah, no, I mean, I think Terry said it right. So when you're trying to implement these new procedures and processes, the minimal disruption you can have to your workflow and your teams, right? So that encounter that happens, there's the understanding that how the check-in process works, and then when do you have the doctor, the nurse practitioner, come into the exam room? Then what's that checkout process like? So everybody is operating at the top of the license. People say that, but when you try to implement this in a virtual setting, things like those small things start becoming huge, right? Like, do we collect the copay for the patient? I mean, this happened to me literally. Like, my doctor's office went to Zoom, and I was about to hit the Zoom button, and I get a phone call, and it was a nurse trying to collect a copay while I was trying to join the Zoom call. It was just, come on, guys, you got to figure this out, right? So this is the kind of things that people are learning how to manage these kind of encounters now. And so for us, the key takeaway that we learned was map your workflows as much as you can into a virtual environment, so that everybody's still doing the same thing or close to doing the same thing in a physical environment, but they're now doing it in a virtual process, right? So that's what allowed us to scale very quickly at these institutions, because there's very minimal disruption. Everybody still understood what happens in the check-in process, what happens after the encounter. You just have to make sure that your technology fits into what they're already doing, rather than have them change to use your new technology.
Yeah, the old adage, people don't love change. That comes into play, right? It's great comment there. So, Dr. Brennan, how about you? Give me some thoughts, best practices.
Yeah, so I think Terry and Dr. Pullum hit it right on the head. The trainings, the workflows. For us, as the end users, you got to recognize every time I put something new in, I got to pull somebody out to train them. And if it's not really going to help their workflow, they're really not going to use it. So what I like to always say is more is not always better, even though I like shiny new toys. But sometimes we just have to take a stop and say, okay, well, wait a second, is that really what the end user wanted? But with that being said, the other thing from the healthcare provider standpoint is we have to be fluid. We have to be open to collaboration and open to change. We have to make sure that we're understanding how this is going to benefit our patients at the end, because at the end of the day, everything that we do is usually based on what is the best output for the patients. I would think two of the best practices, though, that I would like to share, especially with my IT colleagues here, is always look at interoperability and always look at the logic. One of the things that we did recognize very early on is I had 321 agency nurses from across the United States come into New York City. 321 nurses that all had experience, but I had to stop and teach them how to use every bit of technology I had in the building, which stopped me from putting them out. Now, yes, there is logic to an IV pump, but one IV pump versus a different pump, there's different logics. So, so I think as we go forward, and you asked me about 5 years down the road, I think we got to get a little bit better at making sure that we use standard logic and we have standard interoperability. I'm not really great with those little, what do they call them? The things that go from one to the other and connect. Oh, there's a name for them, and I just totally blanked on it. But there are certain programming pieces that, it gets us all for cuts because we think we have a solution and then we need to add something to it. So I think that's where our IT colleagues really bring immense knowledge, because you guys know all about that, and I wouldn't be able to do my job if it wasn't for you all. And just again, not losing sight of the access issues. The access issues, the social determinants of health, things like that may, while we think of providing access to everybody, are not. So I think that's where our creativity, our grants, our funding need to start to engage with our legislators.
Yeah, that's great insight, Dr. Brennan. So Rick, take me home here.
I'm not sure if there's anything I can really add to that. I would just put it in terms of where I see the prioritization for the industry, right? So Dr. Brennan's point first, it needs to be easy to use by the clinician and easy to use by the patients. They have to have access to it or it won't be used and it won't be an effective tool. The next advice I would be is protect your remote workers and protect your organization, right? PHI is critically important and in high demand, right? And when I say protect, I'm not just talking about from cyber actors. I mean, protect them from burnout. You know, something that Rob Zamp and I have to deal with all the time is, webinar burnout. I'm literally on these darn webinars for 10 to 12 hours a day. And it's weird, in a real life environment, you can go and get a cup of coffee and we can joke around and I can ask him about his wife and his kids. You don't get that kind of break in this world. So make sure you're taking care of your caregivers, because I'm really worried about that. And then the last thing I would say is take this opportunity to harness the technology. Don't let the technology drive you, but harness the technology to improve your mission, right? Learn from these sessions, figure out where you can automate, figure out where people need a personal touch point. And I think if we can do that, we can improve the overall patient health and even population management, because we can learn so much more from it. But it's just been such an exciting time, right? And, it is, COVID is a major stressor, but in great times of disarray, we have a great opportunity to be able to improve. Now we have to take a step back and say, all right, is everything that we're doing, is that in the best interest of our patients and in the best interest of our caregivers?
Well said.
Great insight there. We have a few more minutes actually. Tony, you want to jump in?
No, go right ahead. Finish up.
Oh, was one more question in the chat. I just noticed it's an interesting one, and I'll give Terry a crack at this one. So, have you seen any reduction in readmission to the hospitals in using analytics and telehealth? Is there a correlation?
There is a correlation. We are starting to see that as we're increasing since COVID is coming lower. Early on, it was hard to tell because people just didn't want to go into the facilities. So I think we're starting to see that now. And, we're strategizing that data and, how we can leverage that for our patients to improve outcomes. But we're definitely starting to see that number come down, where the more people who are having telehealth vision are following up with their providers, they're following the methodologies that their providers providing, and have easy access to ask the questions that they may have forgotten. And we're coming up with ways for them to receive that information so they don't forget. So so they're liking that as well, because they can share it with their families and, provide or even ask for explanation from their families, like how they would interpret it. So I think that it's really important for them. And I think that that's changing how we provide care and how we limit the number of times patients are coming back in for same or similar scenarios of medical needs.
Yeah, that's great. And we're about 5 minutes out. I'm going to turn it over to Tony Ferrante in a second from New York State HIMSS. I'd just like to say thank you to all our panelists. You folks were enlightening, your troopers in your, for your organizations and for this industry. And I personally want to thank you for taking time out of your days, your busy schedules. And I really enjoyed and learned a ton on this hour and a half that went by very quickly. But again, thank you everybody for your participation. And I'm going to turn this over to Tony Ferrante.
Rob, thanks very much. Great job in being a moderator with a super panel of folks here that just kept me on the edge of my seat. And I'm sure that was the same for a lot of the other folks that were on. So I appreciate everybody taking their time. Again, this is another series in what the New York State chapter of HIMSS has been able to produce. And I'll ask everybody to look forward to our next couple that are coming up. We have 3 coming up in the month of May. So look for those invites to come out. We have another one coming up at the 28th of this month from one of our other partners, HEC. So again, great information what all our members can share. And Rob, thank you, and thank Veritas for sponsoring the event. We appreciate it. Dr. Brennan, thank you. Appreciate it. Terry Vetter, thank you. Dr. Poolham, thank you. And Rick, great insight from a technical point of view, and we appreciate everybody and all their time. And all of those that were able to stay on for our hour and a half today, thank you very much. It was terrific. And Joe D, thank you for starting everything off for us today. Everybody have a good day. And that's a wrap.
Thanks, Tony. Take care, everyone.